tumor seen on MRI. It shows the importance of MRI imaging for these patients. Let me talk a little bit about bony limb-sparing surgery for these patients, the ability to take out a large segment of bone. This is a tumor that occurred in the proximal tibia. The tibia is the large bone in your calf. It represents the lower half of your knee joint. Here's the knee joint. Here's the femur. This is a tumor that's making a white image here in the proximal tibia. It's a bone-forming tumor called an osteosarcoma. We see it in teenagers and young adults. Here's an MRI of the same thing. This is the proximal tibia. This is the abnormal area of the bone tumor. Here's the tumor going out of the bone into the soft tissues. And here's the knee joint up above. This entire bone is resected out and replaced with a proximal tibial replacement here. Here's the knee joint. Here's where the tibia was cut. And this metallic bone plus the knee joint is very functional in these patients. So when we combine the big step up that we've had with imaging using a PET scan, here's a lower extremity tumor, again in the thigh. This is a tumor in the anterior thigh. This is the left thigh with a tumor in it. This is the right thigh, which is normal. This is the patient when they first came in. They had this large tumor in their thigh with a pretty hot-looking PET scan. The number on that PET scan with the uptake value was 14.3. They got 2 cycles of chemotherapy. Their PET scan improved dramatically. Their PET scan number now was 4. The MRI showed some improvement, but not the dramatic change you see on the PET scan. They had their surgery and their tumor removed after this PET scan, where the number was again lower after a few more cycles of chemotherapy, and that patient's doing very well with a good response. These type of imaging has allowed us to do more functional surgery. We could take tumors out where we didn't used to be able to take tumors out. We can combine that with bony surgery in patients who have osteosarcomas and Ewing sarcomas, and we can really improve the function of these patients at the same time that they were increasing their survival. Here's an extreme example of a difficult case. It shows you the imaging that we have for these patients now. This is the old-fashioned imaging of a plain X-ray. If you see very carefully, here's a bone-forming tumor in the first or second rib of this patient's chest. This is an arteriogram that shows the blood vessels going to this tumor. It shows a subtle blush or an increase in small blood vessels around that tumor. This is a CAT scan that's a cross-section cutting like a loaf of bread across the body. And this is the trachea in the front, spinal cord in the back, and the first rib, and a large tumor here. This is an MRI that shows a large tumor here. This large mass is all tumor directly abutting the spinal cord. Here's the spinal cord with tumor beginning to invade the spinal cord. This patient was given chemotherapy. Their tumor occurred here, the upper thoracic vertebral body, and allowed an operation that would otherwise not have been doable without chemotherapy and without good imaging. So this is an example of the improvements in imaging, the improvements of biology, in addition to the improvements of chemotherapy and surgery that's had a huge benefit in all of our patients. Patients are seen at the Seattle Cancer Care Alliance by these referral numbers. They're seen in our regular bone tumor clinic here. And they can also be referred through the website, through this website for new patients. We hope that in the near future, with continued improvements of metabolic imaging in sarcoma patients, carefully monitoring new drugs and an early response to treatment, understanding the biology of these patients, that will improve the cure rate of all these patients dramatically in the next 4 to 5 years. I'd like to change stride a little bit now and sit down and have a discussion with a couple of the patients that we have today in the studio about what their treatment has involved. We're back with 2 of my favorite patients, Ina Hibbs and Becky Greenway. Ina had a soft tissue tumor in her calf that we treated several years ago, and Becky had a bone tumor that was treated more than 10 years ago. So she has a long perspective on the care of patients with bone tumors. I thought it would be helpful to talk about diagnosis issues and how a patient presents initially, because that's a huge issue for many patients, because it's very difficult to make the diagnosis, and then talk a little bit about your treatment and the treatment of soft tissue tumors and the treatment of bone tumors. So Ina, thanks very much for being with us for today. Tell me a little bit about how you presented with your tumor in your calf.
Initially, I had jog a lot and do a lot of hiking and things like that, and so it seemed to my husband and I that I had like a shin splint or something. So we treated it for about a year at our house. I treated it with ice and heat and things like that. Eventually, it got really quite a bit larger than my other leg, noticeably larger and hard. So I used to say I have one good leg and one bad leg. Anyway, I went to the doctor, and fortunately for me, the doctor that I went to see was an intern who had just done a circuit, or whatever they call it, rotation in your area. And so the doctor that was there, a normal doctor, said, well, it's probably tendonitis or something, treat it with ibuprofen. And I had been taking ibuprofen already. And she said, well, she'd rather see me have a CT, which she did, and from there I was diagnosed.
Which is the only way to make a diagnosis early on. So the average patient who presents with a soft tissue tumor has a tumor either in their leg or their arm, more common in their arm, in their leg than in their arm. And they present with only usually a painless mass in that extremity. And the usual diagnostic delay is about anywhere from 3 to 6 months. So picking it up early is important. If it's in a tender area next to a major artery or a major nerve, it can hurt more. It can make you think you have shin splints. And being able to distinguish that from shin splints comes down to being able to distinguish a very subtle soft tissue mass clinically, or getting suspicious and doing either a CAT scan or an MRI. So that's an absolutely crucial part of the equation because of the challenge, because even the very best primary care doctor is going to struggle with making that diagnosis early. It's a very difficult diagnosis. Might be even more difficult in a child, a teenager with an osteosarcoma, or a young adult with an osteosarcoma. Why don't you tell us, Becky, how you remember your presentation?
I had a lot of night pain. Every night it would get worse. The only thing that would help it would be heat. During the day it would feel fine, but at night I'd get maybe 2 hours of sleep. I couldn't sleep at all. The pain was so bad. And I was misdiagnosed for about 8 months, four different physicians. They were diagnosing me with tendonitis and growing pains and giving me anti-inflammatories, putting me on crutches, and it just would not get any better. And an orthopedic surgeon finally looked at it, and he saw the tumor immediately in the x-ray and sent me to see you.
And that's, again, sort of typical for a malignancy in a young adult or a teenager. Clearly, teenagers and young adults are usually beating the heck out of themselves playing recreational sports and stuff and getting sprains and strains. And those are very, very common, and separating out a very subtle osteosarcoma around the knee joint is difficult. Usual delay, again, is about the same as 3 to 6 months, and you don't see it until you're at least several months down the road and not getting better from your quote-unquote strain or sprain, and begin to get your first x-ray and getting suspicious from that, hopefully, with some more imaging. The typical symptomatology for a malignancy of bone is, especially in a teenager, is to beware night pain in a teenager. Night pain from growing pains. Growing pains occur in children who are well under the age of 10 usually. Mm-hmm. So if you get into the teenager ballpark with a kid who's having night pain or a sprain that's not getting better after a couple of months, you're beginning to get on thin ice with regards to the confidence of your diagnosis. Let's talk about treatment a little bit. You know, you're the typical, most common soft tissue sarcoma in an adult sort of scenario. You came in with a large tumor in your calf. We did a biopsy. We decided that it was high grade. We gave you chemotherapy up front. You were just treated in the last 2 to 3 years, so you got the new sort of treatment with a PET scan. You had an impressive improvement in your PET scan for a tumor in a very difficult location, right around the major vessels in your lower calf. That good response to early chemotherapy, which again isn't done in many places, which is chemotherapy before the surgery, has the benefit of shrinking your tumor, treating your whole body early and of being able to evaluate response allowed us to peel that out of your calf, give you more chemotherapy. Takes about 6 to 8 months to deliver the chemotherapy, sort of chemotherapy sandwich with surgery in the middle. And then at the end of that, you get radiation therapy and you're over your treatment at 8 to 10 months. It's a lot of treatment, a lot of time in the hospital. The surgery, which is a major procedure, almost becomes minor compared to the fun of chemotherapy for 8 months. What are the good things and the bad things you remember about your treatment?
I guess the worst part about it was the time in the hospital. I spent a lot of time in the hospital getting the chemotherapy, and being away from my family was hard. I think I was really lucky because I did respond really well to the chemotherapy, and I didn't really have a lot of side effects. My grandmother had cancer probably 10 years before that, and I think the drugs that they give you now maybe are better, and they had a lot of counteractive kind of drugs that you can take that prevent a lot of the symptoms. So although you get really weak, very tired, and you can't do the same sorts of things you could do before, I could still go to work when I wasn't in the hospital and that sort of thing.
Becky is 10 or 12 years down the road from an osteosarcoma the tibia. I'll just show you very quickly the basics of her tumor. Was interproximal tibia. The tibia, again, is the calf bone. It's the lower part of the knee joint. So this is the tibia, this is the femur, and her tumor was here. Even with chemotherapy, you have to take the tumor out, and that involves a huge chunk of bone that we take out. So we take out that tumor after chemotherapy and replace that with a metallic bone and the total knee joint built into each other. So here's her metallic tibia now. This is an attachment for her patella tendon, which is crucial for the function of her knee. There's nothing but skin and bone here at this level. The tibia causes a lot of wound complications, and Becky is a historical example of that. And this is the total knee replacement that also is required with this type of surgery. You can't just cut out the tibia and have your normal femur articulate with that piece of plastic because it wears out your knee joint too quickly. So you have to incorporate a total knee into her femur. So her femur is here, and this is her total knee. This is her tibial replacement. And she was initially treated with a bone transplant that didn't work, had quite a few operations, finally converted it to a metallic tibia. Once this tibia attaches well here to the bone, this is an implant that's modular. And if she ever had any failed parts up here in the knee joint, we can snap those out and take them out and replace them quite easily if we had to do that. So the modularity of this implant, the fixation of it's been a gigantic step up for patients with this kind of tumor. These two patients are exceptional in terms of their courage and their strength. I don't think they're exceptional in terms of how we try to take care of people. I really appreciate you guys taking the time to come up here today. And, thanks a lot.
Thank you.